Hi, it's Alicia, and this is my presentation on atrial fibrillation and management in the elderly. So the case, Rita is an 80-year-old female with a 15-year history of atrial fibrillation. She is currently on Metoprolol, 25 milligrams BID, and Coumadin for her INRs. So a review, what is atrial fibrillation? Atrial fibrillation is an irregular or quivering supraventricular arrhythmia characterized by uncoordinated electrical activation of the atria. Irregular electrical signals disrupt the normal conduction between the SA and AV nodes, leading to atria quivering. It is associated with an irregular and often rapid ventricular response that can lead to hemodynamic compromise. As the atria fibrillate, blood pools and a clot may form in the atrial appendage. This increases the risk of an embolic stroke. In general, AFib is associated with a 5-fold elevated risk of stroke and is the most common arrhythmia. The prevalence increases with age and is associated with a high cost of medical care, with over 2.7 million Americans diagnosed. AFib results from several disease processes. Non-valvular AFib occurs in the absence of rheumatic valve disease, mechanical biprosthetic valve, or mitral valve abnormalities, and it's the most common form. Paroxysmal is episodic and can resolve spontaneously or with intervention. Permanent AFib carries the same long-term risk of stroke as paroxysmal AFib. Permanent AFib causes atrial remodeling, which can perpetuate the arrhythmia. AFib caused by valvular heart disease carries a higher risk of stroke than non-valvular, and when AFib is caused by non-cardiac disease, it is referred to as secondary AFib. The 2014 AHA guidelines and classifications note that paroxysmal AFib is AFib that terminates spontaneously or without intervention within 7 days. Episodes may recur with variable frequency. Persistent AFib is defined as AFib that fails to terminate within 7 days and often requires pharmacologic or electrical cardioversion to restore a sinus rhythm. Long-standing or persistent AFib is AFib that has lasted for more than 12 months. And permanent AFib is a term used to identify individuals with persistent AFib where a joint decision between patient and clinician has been made to no longer pursue a rhythm control strategy. So diagnosis, the patient may present with mild or no symptoms of heart failure, MI, stroke, or hemodynamic changes or collapse. The most common symptoms are fatigue, palpitations, chest pain, syncope, dizziness, edema, dyspnea, and orthopnea. A physical exam will focus on blood pressure, heart rate, presence of a cardiac murmur, and evidence of heart failure. A history including onset of symptoms, precipitating or alleviating factors, comorbidities, and identification of risk factors is important. In reviewing a patient, the H&P should focus on both potential cardiac and non-cardiac etiologies, identifying the duration, aggravating and alleviating factors, and the severity of symptoms. Contributing factors can often include sleep apnea, thyroid disease, recent illness, and use of any new medication or over-the-counter supplements. Furthermore, an assessment of illicit drug use, alcohol, or diet pill use should be established. Initial lab tests include a CBC, BMP or electrolyte panel, thyroid stimulating hormone, and liver and kidney function. Imaging can often include a 2D echo to evaluate both structure and function of the heart, a chest x-ray for pulmonary disease. Additional testing that may be prudent given risk factors would include stress echo, stress test, cardiac cath, drug screen, and sleep study if sleep apnea is suspected. So the 12 lead and EKG findings, key findings on an EKG are the loss of P waves with replacement of fibrillatory waves, erratic activation of the ventricles leading to an irregular and often rapid rate. A narrow QRS is common unless there are other conduction abnormalities present. Cardiac rhythm monitoring will reveal that the R-to-R intervals show no repetitive or regular pattern. This is often referred to as irregularly irregular. Sympathetic and parasympathetic activation can exacerbate or worsen AFib by shortening the atrial refractory period. This increases the susceptibility of reentry and enhances automaticity. Suspected AFib based on evaluation of pulse rate should always be confirmed with a 12-lead EKG. However, a normal EKG does not completely rule out the presence of AFib as it may not capture paroxysmal AFib. If PAF is suspected, a Holter monitor or event monitor may be required for diagnosis. So what do we do? What are the goals of treatment? There are two principal management decisions in AFib. The first is, does the patient need long-term antithrombotic therapy? All patients whose risk of embolization exceeds risks of bleeding are candidates for anticoagulation. The second question is, should the patient be managed with rate or rhythm control intervention? This is determined based on severity of symptoms, presence of structural heart disease, adequacy of rate control during episodes, and obviously the patient's preferred preference for using drug therapy or undergoing interventions. In our hemodynamically unstable patients, immediate evaluation and treatment is necessary and may include emergency cardioversion. In stable patients, treatment depends on duration and presence of underlying cardiac disease as well as other comorbidities. In general, AFib treatment poses major therapeutic dilemmas. These include how to best control the ventricular rate, whether a procedure to convert back to a normal sinus rhythm is safe and advisable, and whether an anticoagulant should be started and which anticoagulation to start. As far as rate control, it's an essential part of treatment in acute and chronic settings. It promotes hemodynamic function by slowing the ventricular response, improving diastolic ventricular filling, decreasing myocardial oxygen demand, and improving coronary perfusion and mechanical function. Considering the challenges of both achieving and maintaining a normal sinus rhythm and deleterious effects of antiarrhythmic drugs, most patients with AFib are treated with rate control. Beta blockers, along with calcium channel blockers, are used to achieve rate control. Rate control kind of falls into a couple of categories. Lenient category with a resting heart rate less than 110 may be reasonable. Stricter control with rate control under 80 beats per minute may be required to resolve symptoms in certain populations. We are looking at selective beta blockers here. Non-cardioselective beta blockers are contraindicated in patients with acute heart failure, severe chronic obstructive pulmonary disease, and asthma. Digoxin is no longer considered a first-line agent or recommended monotherapy, but can be added to therapy with beta blocker or calcium channel blockers. And lastly, amiodarone offers choice for rate control when the above-mentioned methods are ineffective. However, it has delayed action, potential toxicity, and numerous drug interactions, which may severely limit use. Outside of medications for rate control, there are forms of electrical cardioversion or ablation as options. Again, this is weighed based on the patient's wants for treatment and whether they are a safe and appropriate candidate. For anticoagulation, that it's an essential part of AFib management as well. It reduces the risk of embolic stroke, but does increase the risk of bleeding. And for most patients, the benefits of anticoagulation far exceed the risks. For years, the CHADS-2 score system has been used to estimate risk for stroke in patients with AFib. According to this model, anticoagulation is recommended for patients with a score of 2 or more unless a contraindication is present. Most recently, the CHADS-2 VAS score has been recommended by the American College of Cardiology. And in that score, anticoagulation is recommended for patients with a score of at least 2 with no contraindications. It does significantly increase the number of patients eligible for anticoagulation compared to the CHADS-2. Additionally, similar tools are available to evaluate anticoagulation bleeding risk. There is the HAS-Blood scoring system, which has been used with a score of 4 or more, indicating that patients will have a high likelihood of hemorrhage. So this is just the AAFP algorithm for evaluation and treatment of patients with AFib. Again, it's a general algorithm, and each patient will potentially deviate, but it's a nice kind of condensed version of how to approach it. This next slide is a comparison of the CHADS-2 and the CHADS-2 VASC risk stratification scores for non-valvular AFib. And this is just an atrial fibrillation anticoagulation algorithm. All right, let's get back to Rita. So Rita is a Caucasian female who has a history significant for CAD, hyperlipidemia, AFib, and osteoarthritis. Her surgical history includes 2 C-sections and a hysterectomy. Her family history is significant for CAD in both her mother and father. Her father deceased of a heart attack at 87 and mother of heart failure at 90. She has 2 children, both female, ages 55 and 58. Both are alive and healthy. She's a never smoker. She denies illicit drug use and drinks 1 to 2 glasses of wine per week. She walks daily with her dog 1 to 2 miles. She lives in a single-story home with her husband. She moves well about her home, tends to her daily needs, and has had no recent falls. She follows a regular diet. She avoids high sodium foods, reports good appetite with no significant weight changes, and she has no allergies. Rita's med reconciliation shows the following: metoprolol tartrate 25 milligrams PO twice daily, and Coumadin with dosing from the local Coumadin clinic. She reports her most recent dose at 5 milligrams daily every evening. She does report occasional use of ibuprofen, 400 milligrams every 6 hours for her aches. She reports her last dose is last week and just 1 day. She states she never takes more than 1 dose in any day. Other than that, she denies any over-the-counter meds or supplements. So clinical findings and physical assessment, report of symptoms. Rita is complaining of palpitations and fluttering. She says they began recently, within the last week, and have gotten progressively worse. She does note some fatigue when she walks her dog, with some very mild shortness of breath in the last couple of days, again, mostly on exertion. She denies chest pain or dizziness. General assessment: Rita is an older female. She is relaxed and well appearing in the office. She is in no acute distress, sitting on the exam table and speaking full sentences. Her skin shows good color, no cyanosis, no rash. She is normocephalic. Her pupils are equal and reactive to light and accommodate. Her mucous membranes are moist and intact. She has no lymphadenopathy. Her breath sounds are clear throughout. She does have shortness of breath only on exertion. 2, auscultation: her heart rate is irregularly irregular. She does have a systolic murmur, which has been noted on previous assessment. Her abdomen is soft, non-tender, no masses. Her bowel sounds are active throughout. She does have some trace edema to her lower extremities with palpable pulses. She has no joint deformities. She does have decreased range of motion to her spine, knees, and ankles, which again is chronic. She is alert and oriented. Cranial nerves are intact, normal mood and affect, and she has equal reflexes. Her vital signs are listed there, most notably with a tachycardic heart rate in the 120s. Her labs are all within normal limits, including CBC, CMP, TSH, and cardiac markers, and her INR is therapeutic at 2.2. It 12 lead does show that she is in atrial fibrillation with rates in the 120s. She had an echo within the last year, which shows left ventricular hypertrophy with an EF of 45% and mild aortic stenosis. So in looking at Rita's meds, we'll first address metoprolol. Metoprolol is a selective antagonist of beta-1 adrenergic receptors. The therapeutic effect is related to its ability to block beta-1 receptors in the SNS at therapeutic doses. Blockade of the beta-1 receptors in the heart and in the juxtaglomerular apparatus yields therapeutic benefit of decreased heart rate, contractility, and excitability, as well as membrane stabilizing effects, which lead to decreases in arrhythmia, cardiac workload, and decreased oxygen consumption. It is metabolized by the liver, CYP450, and excreted in the urine, and has a half-life of 3 to 7 hours. Chronic beta blocker therapy is utilized in atrial fibrillation and decreases resting heart rate and blunts the heart rate response to exercise. Adverse reactions you can see are listed there. Serious reactions are CHF, severe bradycardia or heart block, cardiogenic shock, angina exacerbation, MI. More commonly, though, fatigue and dizziness, some dyspnea or sleep disturbances, as well as bradycardia. Contraindications are obviously to the drug or compound, sinus bradycardia, a second or third degree heart block, uncompensated heart failure, hypotension, cardiogenic shock, a sick sinus without a pacer, and severe PVD. There are extensive drug interactions for metoprolol like other meds. The most common are clonidine, cocaine, diclofenac, ibuprofen, insulin, indomethacin, and ketorolac. There is a black box warning for beta blockers. So beta blocker therapy should not be withdrawn abruptly, particularly in patients with CAD, but should be gradually tapered over 1 to 2 weeks to avoid acute tachycardia, hypertension, and or ischemia. Severe exacerbation of angina, ventricular arrhythmias, and MI have been reported following abrupt withdrawal of beta blocker therapy. Temporary but prompt resumption of beta blocker therapy may be indicated with worsening angina or acute coronary insufficiency. So Coumadin, her second medication, it inhibits vitamin K-dependent coagulation factor synthesis, including factors 2, 7, 9, and 10, and protein C and S. It leads to thinning of the blood. It is also metabolized by the liver, also by CYP450, and excreted in the urine. Its half-life is 20 to 60 hours in its anticoagulation effect, but that's highly variable based on the rate of clotting factor catabolism. Adverse reactions, so most serious and common, is bleeding or hemorrhage. It can lead to skin and tissue necrosis, gangrene, cholesterol embolism, anemia, acute kidney injury, but most common is bleeding, ecchymosis, some abdominal pain or cramping, feeling cold. Contraindications, it's absolutely contraindicated in pregnancy except in women with mechanical heart valves, if they have hemorrhagic tendencies or blood dyscrasias, recent or planned surgery. It is definitely contraindicated in patients that may not be highly compliant or in malignant hypertension. It has a lot of interactions like other meds. There are absolute contraindications listed there. Avoid use and alternatives will be seen in the next slide. Significant food interactions are obviously noted, so vitamin K-rich foods that can interact with Coumadin include leafy greens, garlic, herbs, cranberry, and grapefruit juice. Again, these are all of the meds that Coumadin can theoretically interact with. And these are the herbal things that can interact with Coumadin as well. So what is my plan for Rita? Given that Rita is at a therapeutic INR with no report of significant side effects, her Coumadin regimen appears to be successful. She has had no recent changes to her CHA2DS2 VAS score at 3, and at this visit she has expressed that after 15 years managing her afib, she feels very comfortable with the regimen, understands her requirements for monitoring and titration with the Coumadin clinic. She understands her dietary recommendations and also understands the adverse side effects to look for. She states she even enjoys the trip to the Coumadin clinic as it gets her out of the house. In the past, we've discussed alternatives, including a DOAC, but Rita continues to decline a change of anticoagulant until we have a problem. Therefore, I will opt to maintain her treatment regimen for anticoagulation. Given her atrial fibrillation with a rapid rate, I will seek to better control her rate with adjustments to medications. At this appointment, she's fairly asymptomatic to the tachycardia, and symptoms appear to be mostly exertional. She expresses apprehension to addition of another medication and is hopeful to control her rate without a lot of new changes. So, first step, I will attempt to adjust her current metoprolol regimen. I will opt to increase her metoprolol from 20 milligrams twice daily to 50 milligrams twice daily at this visit. I'll ask Rita to monitor her blood pressure and pulses prior to doses, and if she's symptomatic over the next 2 weeks, and ask her to bring those records to her follow-up appointment in 2 weeks. If unsuccessful, I could consider further adjustment or consider the addition of a second agent for rate control, like a calcium channel blocker. A calcium channel blocker we could consider adding is diltiazem or verapamil. These block or inhibit calcium ion influx into vascular smooth muscle and the myocardium and cause relaxation of smooth muscle, decreased peripheral vascular resistance, and they dilate coronary arteries and prolong the AV node refractory period. They are considered class 4 antiarrhythmics. If that was unsuccessful, upward adjustment of metoprolol and addition of a calcium channel blocker, I could consider consultation and referral to a cardiologist if she's not already established. Again, I would only do this if her rates remain suboptimal with the above adjustments. I will consider a repeat echo with persistent symptoms without response to this medication regimen to evaluate for any progression of her stenosis or for other contributing structural or pump abnormalities. Rita will also be instructed to report any changes or worsening of symptoms so that the plan that we establish at this appointment can be appropriately adjusted, and I will continue to monitor and rule out other causes as we treat her AFib. So teaching and recommendations for Rita at this appointment will include lifestyle recommendations, including maintaining her heart-healthy diet, physical activity as tolerated, being mindful that her heart rate is not raised too much while we're still attempting rate control, limiting and avoiding caffeine and alcohol, avoiding and reducing stress, and reporting any new over-the-counter meds or supplement herb use. Rita will be instructed regarding her increased dose of metoprolol. Again, she will be instructed to monitor her blood pressure and pulses over the next 2 weeks and report back with her measurements. She will also be instructed that if she should experience any new or worsening symptoms, that she should notify the office, particularly dizziness, shortness of breath, faintness, tachycardia, worsening palpitations, or chest pain. Rita will be instructed to continue her Coumadin regimen. She has previously reiterated her understanding of the teaching and is encouraged to notify of any changes or problems with the regimen. Given Rita's use of Coumadin and metoprolol with occasional ibuprofen use, I would instruct Rita to monitor for adverse effects associated with this combo. Ibuprofen can increase her risk of bleeding along with her Coumadin, so ibuprofen can also decrease the efficacy of metoprolol. Given her pretty infrequent use, I do not suspect that this will be problematic, but she will be instructed to notify if her use increases or if she has issues with the regimen as it stands now.